from Washington University here with us today to help us understand and learn more about having healthy lungs. Go ahead. Thank you.
Thank you. Thank you, Judy, for the introduction and also inviting us to present. So I think I will just present for the first 30 minutes, and my goal is to talk for about 20 minutes and leave time, for us all to kind of discuss, because I think it just makes it more interesting if we have discussion as opposed to me talking all the time. So let me share my screen here. I think I could do that earlier. Okay, could you guys see my screen?
Yes.
Okay, wonderful. Yeah, so just a bit about myself. I'm Li-Shen Chen. I am an associate professor of psychiatry at Washington University, and I am a psychiatrist. I do see patients at BJC Behavioral Health, and for my research, I work on improving treatment for patients, particularly to help smokers, people who smoke, to do better for their health. So, and I think I understand today's topics about lung health, and I'm very happy to talk about the aspect of how smoking or vaping can affect lung health. Okay, so this is my disclosure, and like I said, I see patients at BJC, and I'm mostly funded by research from National Institute of Health. So, on the news, we have always been seeing like the new death toll for smoking, trying to make sure, our convenience store is promoting health. And then we see the news that the Juul is so cool, vaping is coming. And then we also see, well, the schools, it's hard for students to concentrate. The teachers have to, kind of collect all these devices. And then, we also hear research of like even one cigarette a day is really bad for your health. So all these news really let us know that, smoking, is still around, and what can we do about it? So my topics include smoking and vaping. And if we have time, I can touch a little bit on precision medicine, the kind of a future direction of clinical care. Okay, so why do we care about smoking? So we hear, so addiction is a true human condition, and opioid crisis is something that's on the news a lot. So opioid causes about 70,000 deaths per year. In contrast, tobacco also kills people, not directly by overdose, but by just causing heart disease, cancer, or stroke, all these medical diseases that take people's life down the road. And it kills about 480,000 people a year. And of course, that we hear about this, like kind of vaping, e-cig use in the youth, that is really rising in our kids' population. So addiction is a real problem. Surgeon General last year just came out and said that, well, it is shocking that people are not told to stop smoking or stop vaping or just take care of their health. And if you look at the data, that he is right. So this is just data showing that a lot of smokers are interested in quitting, very high percentage, but the success is very low. And the use of treatment is about 1/3. So most smokers try to quit, but they don't really use treatment, even though there are 7 FDA available treatments. So we have the nicotine patch, nicotine gums, nicotine lozenges that taste like a mint, inhaler, and nasal spray and inhaler. And then we have the bupropion, the Zyban, and Chantix varenicline. So these are all available treatment that are not being used. So I like this cartoon because it talks about how it is really hard to be a smoker today. All these policies, all these disincentives, but still, in this country, the smoking prevalence is about 14-15%. So it's like 1 in 7 people, still have this nicotine habit. So that just shows that it is really the addiction. You continue to use even though you know it's bad. I want to share a few stories of patients that I've worked with. So this is a middle-aged man who came to me in the clinic to get help for depression and alcohol dependence. And we also discovered, well, he also smoked cigarettes. So I offer treatment with the medication with him, and he took the treatment and eventually quit. And he actually was so happy that he was able to quit before he turned age 60. And he agreed to do a video with us. And in the end of this short video, his quote was that, "Why did I wait so long?" He really wished that he would be able to kind of get help and be able to kind of change this habit earlier, before age 60. But it's never too late. This is another patient that I work with in the clinic. So her story was that she was, she of course has depression off and on, and other post-traumatic issues. But with smoking, she was able to transition from tobacco smoking to so-called dual use. So it's smoking and vaping at the same time, because her kids gave her vapes and she loves the flavor, and so she uses quite a bit. And that lasted for about 2 years, and eventually she was able to transition to vaping only. So she did vaping only also for 2 years. And then we have just been deciding, well, it is a good idea to be not dependent on nicotine. So we worked together on her treatment to eventually get her off nicotine vaping as well. So this is another story. This is the trash can in my office in the clinic. You can see in the trash can there is a blue box, and that is a cool cigarette box with lots of cigarettes in it still. So this is a 22-year-old young man with schizophrenia, and we discovered he smokes 2 packs a day. And I said, "Well, you don't work, how do you get the money to do that?" And he said, "Well, my parents buy it for me." And I said, "Why?" And he said, "Well, they want me to feel better." And I said, "Well, do they know that you actually would die 12 years earlier because of this?" And we looked at each other and then decided that, well, it might be a good idea to get him on treatment, get nicotine from a safe source instead of getting nicotine from cigarettes, from tobacco. And of course, that day, we are still working on this, and I was offering, using text program apps to help him quit smoking, and he stood up and took out the cigarette box in his pocket and threw it in the trash can, and he said, "Well, today I will quit for Dr. Chen and Ko," and Ko was his caseworker at the time. We were very moved by the motivation, but motivation alone is necessary but not sufficient. So, he eventually quit smoking, after about 1 year with different treatment. And I talked about treatment. So this is another nice guy that's been working with us, and he was able to go on the Fox News with me on the Great American Smokeout. So every year in November, there is this GASO, Great American Smokeout Day, to encourage all smokers in this country to make a positive change. And he said that, well, he tried 13 times and eventually succeeded, and the support, the treatment made all the difference. So we're very, very excited that I think that this is possible, and then we really just need to kind of match people with the help. So is smoking here around us? So this is kind of the smoking distribution in this country, and the darker color indicates more smoking. So you can see we're kind of in the middle of this kind of the dark cloud. If you look at California, the smoking prevalence is about 10%. Overall, the country is about 15%, and we here in Missouri, we're almost close to 20%. So we have a lot to do here. I want to talk about COVID because it's kind of on everyone's mind. So what is COVID's impact on lung health and on smoking? So COVID you can see the title here with Ian. Now is the time to quit smoking. It could increase your odds of beating COVID. So we have been researching COVID cases and smoking, and in our system we have I think we have almost like 40,000 cases of COVID just within the BJC system already. And then what we learned, and not only us but from everyone in a lot of other medical centers, is that if you get COVID, it is harder for smokers to get well. So smokers are more likely to get ICU care, to die from COVID compared to non-smokers, or current smoker is worse than never smoker. So it is true that it is a good prevention to quit smoking to help with the kind of a COVID prognosis. And of course that COVID increased anxiety for everyone. A lot of smokers are very interested in quitting, but unfortunately, without help, this anxiety actually translates into more smoking. And also because of our all working from home, there's less kind of work policy about smoking. So we do see that there's this kind of uptick of smokers wanting to quit, but the actual smoking does not decrease because of COVID stress and lack of treatment. So just a very quick question: what are the this is kind of the idea, no one needs to answer the question, but just kind of the idea of like thinking about question and try to answer as a group. So what are the evidence-based treatment recommended by the FDA? And then these are the 7 FDA approved medication I talked about. The idea of nicotine replacement patch or lozenges or gum is really for people still to get nicotine, but doesn't have all the carcinogens, cancer causing toxins from tobacco, from burned leaves. And then the other 2 medications target at the craving as well. So all these are very, very effective treatment. The second question is the varenicline Chantix. Some people worry about the black box warning, the risk of Chantix causing depression, and that I want to update that black box warning was based on a small study of 100 people. That Chantix could cause more depression, and with newer study of 8,000 people, actually that FDA has lifted that black box. So it's really safe to take these medication. And not only that, it can help people not only quit smoking, but also reduce. The third question, can smoking help with mental health? So this is kind of a long-standing myth that smoking can help with mental health. In the contrary, smoking actually worsens mental health. And there's a lot of studies showing that it is not the kind of the way that we tell, well, if you get upset, just, take a cigarette. It really push people to the opposite side of mental health. How many years do smokers die early compared to non-smokers? And this is a striking study of many thousands of hundreds of people. And you can see here, I want to point out here. So never smoke. So this line, never smoke, is us, for people who don't smoke. Smokers, for us, those who smoke, there is about a kind of a 10 to 12 year difference dying earlier. But the good news is that if you quit before age 44, you get 3 out of the 12 years back. If you quit before age 54, you get 6 out of the 12 years back. Even if you quit before age 64, you get 4 out of the 12 years back. So the message is never too late to quit. You can always gain back the years. So that's very positive news. And I want to talk about the counseling to help people quit smoking is really meeting people where they are, work on the motivation, work on the actual quitting, work on maintaining that quit status, so there's no relapse. Okay, and I'm going to talk about vaping a little bit. So, what is vaping, And what are the electronic cigarettes? So they come in many shapes and forms and color. As you can see here, they're designed to be very attractive, modernistic, to deliver nicotine to your lungs in a very efficient way. And the idea is that nicotine is addictive. So if you like nicotine, nicotine keeps the habit going. So vaping does become a habit. And because nicotine is highly addictive, it becomes a very effective way of maintaining people's behavior of doing it again. And the wonderful design makes charging easy, makes it look cool. And so vaping is a very efficient delivery system for nicotine, and also kind of creating a new behavior pattern. So what is in the vaping smoke? Usually the vaping creates kind of a big smoke, and there are kind of parties to kind of share how you can actually vape and create all these wonderful shapes and hollows. So definitely there's nicotine in it, because that is the primary driver to sustain this repeated behavior. There is flavor. That is also another very attractive feature of vapes. It can be chocolate mint, it can be strawberry, it can be any wonderful flavors that people put in ice cream, and you can put that in the vapes as well. And also there is the kind of the glycerol that helps the liquid, to contain these ingredients and evaporate. And there is this kind of the metal component comes in, because it is a device with the heating compartment. And then there is some metal detected in the vapes, in people who vapes, and also in the vapes. So it is a mixture of things. It is unlike tobacco that has a lot of combustible burnt leaf products. So electronic cigarettes is nicotine plus other things as well. Okay, who vapes? So it is our young generation. So vaping has kind of become viral in the younger generation, very popular in high school, middle school kids. You can see a recent survey, about 10% of middle school and almost 30% of high school kids have tried it. So it is a very kind of common entertainment. And now in the older adults, vaping is mostly used by current smokers as an alternative, or former smokers to kind of reminisce about smoking. But in the younger generation, it is a new behavior from people with no prior tobacco use. Is there any harm of vaping? I'm just checking to make sure we're good with time. So I have a few minutes before we go to the discussion. It is considered there is still harm with vaping. Of course, nicotine itself could present danger to health. And the second type of harm comes from all these other ingredients. The flavors are designed to be ingested, in food, but now it's being heated up and become vapor. So there are additional chemicals generated in that process, and the metals and glycerols have been found to also cause cancer in the labs. So it is still being worked out. And of course, there's this kind of combustible, is a battery run device. So there is some danger there. Vaping or cigarettes? So this is kind of an important question. Is there less harm for vaping? And so should we encourage smokers to make a switch? And we generally recommend smokers to use FDA-approved treatment first. Like I said, the patch, lozenges, gums, and these medications are safest option. For those who have failed these treatments and really continue smoking, in that case, vaping is safer than continued use of combustible cigarettes. However, there are some cautions, two cautions really. One is that it's better just to do a complete switch instead of dual use. The research has found that if you continue dual use, meaning smoking cigarettes and vaping at the same time, the amount of carcinogens you get from smoking has not been reduced. So you have to get the benefit if you make a complete switch. And some people cannot do that because cigarettes ultimately is maybe more rewarding than vaping. The second is that do not use flavors, because flavors are really bad and increases the risk. Okay, and I think we are, I've given a lot of information. If I may just go to the last couple slides, so we have a lot of resources from Simon Cancer Center, and Anne is going to talk more about what other help that's available here. But I want to just leave the last message about the future, because I think we all, we're very fortunate that I think that, Washington University, Simon, and also, our country values how we can always improve care. So there is this precision treatment initiative to make sure that we want to match people with the right treatment for them. So there is ongoing research to make sure that you, based on your personal genetic or biomarkers, that you will be prescribed the most efficacious treatment for you. And that is kind of is an active research here at Washington University. Okay, so I will end here. Of course, this work is from many, many people at Simon and also across this country. And I will end here and really, really, look forward to having more discussion with you all, because you're all out there. I know COVID, we're all kind of isolated, but I think we're all have our personal experience. I don't know whether you know of anyone, family, friends who have smoking or vaping and kind of like to share your thoughts or comments will be very much welcomed. Thank you. I would stop sharing here. Okay.
Yeah, and maybe as we get ready for Anne, we did have one question that came through. It does seem like there is a difference between cigar smoking and cigarette smoking, where there is an exception for people smoking cigars in our society. Is that, do you know much about why that could be, or is there similar links to cigars and cigarettes?
Yeah, thank you. Thank you. That's a great question. So the question is about the different tobacco nicotine products, and are they all equally harmful, or actually there is kind of a different distribution? This is an excellent question. I think that in the ideal world, we should say, well, no, none of the products, right? But the truth is that I think people need to know the accurate risk associated with all the products. I would say the highest risk will be the tobacco products, the cigarettes, and I think cigars and cigarettes that involve kind of burning of the actual leaves in the process of combustion, burning, does generate quite a bit of carcinogens. So, and these can be measured, in the labs by the inhaled, exhaled carbon monoxide, and we find smokers have very high level of the carbon monoxide, just even sometimes higher for chronic smoker, higher than what the firefighter, could have. Firefighter, they often would go and fight fire, but then sometimes when they inhale too much of those combustion, it's bad for their health. So smokers are kind of chronically living that. So I think combustible products have really the highest harm, and the level depends on the person's use amount and the person's metabolism as well. So in our labs, we do measure all these carcinogens, and we'll be able to quantify that, at least the basic level of how much the toxins, the carbon monoxide. Now there is the next level is also tobacco products, but these are chews, right? So these are snus, the chews. They're more commonly used in rural America. And I would say these are also harmful, but they may be a little bit less compared to combustible products, because they are mostly affecting the oral health. And then there is this kind of IQOS. I don't know what you heard. This came from Japan. The IQOS is cigarettes, but they smoosh up the cigarettes and they don't burn it, and you just kind of heat up. So you get this kind of vaping, of that. And so this and electronic cigarettes are kind of trying to dissect out the nicotine from the other ingredients. And I would say safest will be the nicotine patch, lozenges, or the inhaler or nasal spray, because these are FDA approved products after toxicology studies, and to show that it's a delivery of nicotine, but doesn't have the minimal of any other product that can cause harm. So back to your question, I would say cigars, the risk of cigars, and I was for a smoker, I think you really think about how can I do harm reduction, right? So smaller quantity and shorter duration, less exposure is always better. Yeah, I hope that.
Yeah, that was very great. Thank you. And what about secondhand smoke? How that falls on the levels of combustible smoking to vaping?
Yeah. That's an excellent question. So the secondhand smoke, thirdhand smoke has been a very salient problem, especially, I just want to give you a story. Like, in our NICU, like newborn ICU, right? So we will have the parents coming in and they're going to bring the baby back, and you can smell, the cigarettes, with the coat or jacket of the parents in. So I do think that there is that the concern of the secondhand smoke, and so a lot of policies, have tried to minimize that of the work policy. But at home, it's where it's hardest. So and I think that we try to again, coming back to the harm reduction ideas, is that we try to really care for the person, and also care for to include the environment, our patient lives in, and oftentimes we encourage the whole family, trying to put together. If you live with someone who smokes, it's harder that way, and so I think it requires a paradigm shift, because it used to be that we think smoking, is your personal choice, and sometimes people worry that, well, I don't want to tell you to stop, but I think that because of the secondhand and third-hand exposure, I think it does create risk, especially for our vulnerable people, like kids, children. And I want to say that when we measure the carbon monoxide, we do measure the secondhand, people can get that. You can actually get that just by kind of walking in the traffic with inhaling lots of the bad air, and then you can have that. And so smoking secondhand is really just like you live in this chamber, or you just spend your time all like in the back end of the car all day.
Is that so? Does secondhand vaping smoke have a similar effect? Has there been many studies on that?
That's a very good question, because we have patients who say, "Oh, I don't have marijuana. I just spend time with my friends. They all, like smoke pot, in the car, and that's why I get that." So, that's a very good question. So the vape does contain nicotine in it, and also the other things, the wonderful mint flavor, So I would say that there is exposure from secondhand, and really for that reason, I think vaping is banned in most public places, just because it's not just for personal use. Like you can just put on a patch or do the gum by yourself. That doesn't spread your contents to anyone else. But as long as it involves the lungs, since we share our air, right? So it does share that way. But that's an excellent question.
Well, I'm sure we'll have many more. We'll save those towards the end. Thank you all for your questions so far, and thank you, Dr. Chen, for that presentation. And now we'll move to Anne. And if you have any more questions, please continue to add them to the chat, and we'll leave some time at the end to discuss those.
Wonderful. Thank you so much for inviting me to speak today. And I think this will be a wonderful presentation to kind of go along with all the important information that Dr. Chen has shared with us. So my name is Anne Stilanovic, and I am the supervisor of Siteman's lung cancer screening program. I do not have any financial disclosures. And can you all see my screen okay? Just want to make sure before we jump in.
Yeah, and I think we can see it, but it's in that kind of presenter mode that,
Okay,
yeah.
okay. Let me try resharing here.
Okay.
Thanks for pointing that out.
Mhm. Yes, perfect.
Okay, great, great. So our goals today are to appreciate the motivations for why we screen for lung cancer, to recognize some of the pros and cons of lung cancer screening, and understand more of the lung screening process, including who's eligible, insurance coverage. We'll also touch on some of the highlights of our program at Siteman, and then how lung screening can provide opportunities for smoking cessation and why it's important to continue with annual screening. So as Dr. Chen touched on, we have a very high prevalence of smoking in the US. Nearly half of the US adult population are current or former smokers. And the Midwest has one of the highest rates of current smokers. So why do we want to screen for lung cancer? It is an aggressive disease with a high mortality and low long-term survival, despite new advances in treatment. It is the leading cause of cancer death in the US and the world. And although there's declines in the smoking rates in the US, there's still at least 94 million people who are current or former smokers with an increased risk. And Missouri has one of the highest rates of current adult smokers in the US with around 19%. And I think that Dr. Chen actually did share this map, but in 2018, Missouri was ranked with the 10th highest smoking rate in the US. So looking at the leading sites of new cancer cases and deaths from 2018, we can see that lung cancer is the second most prevalent cancer in both males and females, with greater than 230,000 new cases each year. And it is the most lethal cancer with greater than 150,000 deaths per year. So looking at the US trends in death rates over the past 90 years in women, we can see that the curve is heading in the right direction. However, there's still such a large gap between death from lung cancer versus death from breast cancer in women. The same is true for males. There is still such a large gap between lung cancer deaths and the second highest cancer killer in men, which is prostate cancer. As you can see here, the best survival rates are for early stage localized cancer, and the worst survival rates are for later stages, when the lung cancer has spread to distant parts of the body, such as the brain, bones, liver, or even sometimes the other lung. Unfortunately, this is the point when most lung cancers are found, since many patients don't start exhibiting symptoms of cancer until the cancer has spread. The overall average 5-year survival is around 19%, which has been stable for decades. Now we're going to shift gears here a little bit and take a brief look at the history of lung cancer screening. The Mayo Lung Project was a randomized controlled trial of lung cancer screening that was conducted in the 1960s. There were around 9,000 male smokers that participated in the study. And then in the 1990s, the prostate, lung, colorectal, and ovarian cancer screening trial examined whether screening with a chest X-ray in persons over age 55 could reduce mortality from lung cancer. So when we look at the results of these early studies with chest X-ray, with or without a collection of sputum, the good news is that more cancers were found, cancers were in their earlier stages, and the 5-year survival was better. The bad news, however, was that there was no long-term mortality benefit. Collecting sputum samples provided no additional benefit. And the patients that could not undergo surgery remain the same. Some of the limitations of these early studies was that there was no unscreened control group. There were some issues with compliance and contamination between the screened and the non-screened groups, and the follow-up time was too short to detect a screening benefit. In the late 1990s, we start to see advances in CT technology. It was now possible to obtain high-resolution images of the chest in a single breath hold with a low dose of radiation. Initial pilot studies with this new technology showed that low-dose CT detected more lung nodules and cancers than a chest X-ray. So low-dose CT screening was first reported in Japan, and then also studied in New York in the 90s. Then there was a large 33-center trial that was funded by the National Cancer Institute in the early 2000s. This study did involve more than 53,000 people in the US, including almost 4,000 patients at WashU and Barnes Jewish Hospital. Participants were between the ages of 55 and 74, and they were required to have a smoking pack history of at least 30 pack years. And they had to be either current smokers or former smokers that had quit fairly recently within the past 15 years. They had to have no signs or symptoms of lung cancer or a history of lung cancer. So participants in this trial were randomly assigned to either receive 3 annual screens with either a low-dose CAT scan or with a standard chest X-ray. So it was shown through this trial that you would need to screen around 320 people in order to prevent 1 death. And this can be compared to the number needed to screen for mammography, which is 84 to 377, depending on age and other risk factors. So with the results of the trial, it was shown that there was a 20% lower lung cancer mortality in those patients that received the CAT scan rather than those that received the chest X-ray. So shortly after the results from this big lung screening trial were released in 2013, the U.S. Preventative Services Task Force gave lung screening a grade B recommendation for those people that fell into the high risk category. They recommended annual screening in adults aged 55 to 80 who have a 30 pack year history. They do recommend that screening be discontinued once a person has not smoked for 15 years or develops a health problem that would limit their life expectancy. Around the same time, these other organizations also endorsed lung screening with low-dose CT. And we start to see more public awareness, messaging, and ad campaigns about lung cancer screening in the community. So going along with the U.S. Preventative Services Task Force recommendation, In February of 2015, the Centers for Medicare and Medicaid Services released a decision summary on lung screening, saying it would provide coverage for this test on a yearly basis for patients that met the following criteria. They lowered the age range from 55 to 77. Patients have to be asymptomatic, have at least a 30-pack year smoking history, and they have to have a written order for a lung screening from their physician. And then before the very first lung screening, they have to have a documented discussion with their healthcare provider about the risks and benefits of lung screening. And then all of the data on these patients is required to be sent to an approved CMS registry. So this is a challenging concept for some to wrap their heads around, the pack year history. What is it and how do you get that number? So basically it's looking at the number of packs per day that someone has smoked, saying that that's about 20 cigarettes per pack. And then you multiply that by the number of years smoked to come up with the patient's smoking history, pack history. So current insurance coverage for lung screening in our area, Medicare, also both Missouri and Illinois Medicaid and Gateway to Better Health, and most commercial insurance providers are providing coverage for this exam on a yearly basis as a preventative exam. The screenings do need to be scheduled at least a year apart from each other. And then here at Siteman, we do have an option for patients that are under and uninsured to be referred to our hospital's financial assistance program. Once they apply, they could potentially be able for them to cover the full cost of the test. So I mentioned the shared decision-making visit with the ordering provider. This has to take place before the first screening exam, and it is required for the insurance coverage. During that visit, the doctor will discuss the risks and benefits of screening, the importance of being screened every year, and then just discussing with the patient that it is, by undergoing screening, you are willing to undergo further diagnostic and curative treatment if something were to be found. And then also just kind of discussing the potential impact that this may have on patients' other comorbidities. And then also during that visit, the provider will bring up the importance of smoking cessation. And if they're a former smoker, the importance of staying abstinent from nicotine. And then connecting the patient with tobacco cessation counseling services as needed. So these are the key benefits of screening. The screening test is very fast, painless, and non-invasive. I always tell patients the actual test itself is under 2 minutes. There's no needles or contrast dye involved. Screening can prevent some people from dying of lung cancer. It often finds lung cancer when it is small, before it is spread throughout the body, and before it causes any symptoms. Finding the lung cancer earlier makes it easier for the doctors to treat. It allows for more treatment options and allows for a better chance of survival. Lung screening also might show other significant incidental findings in the chest and upper abdomen. This definitely might be helpful if it's something that can be treated. So possible drawbacks of lung screening is that there may be a false alarm. So about 15 of every 100 people that screen for the first time may have a false alarm where the lung screening shows something that looks like lung cancer, but is not actually lung cancer. Now, the risk of having a false alarm goes down when patients are compliant with annual screening and come back every year, because then we can compare to their prior screenings. There is a risk of being exposed to some radiation during the procedure, and the amount that they're exposed to is about the same as the amount of radiation that you're exposed to in the air in 4 months. So it is pretty low. There is a small chance that the patient could be treated for a lung cancer that would have been so slow growing, it wouldn't have been a problem for them. They likely may have died from another comorbidity before dying from lung cancer. And then also just thinking about time and money. For screening to be as effective as possible, the CAT scan does need to be done every year. This takes time and can cost money for those that don't have health insurance. The patient may be responsible for any co-pays or deductibles that might be needed for their further diagnostic testing. So the American College of Radiology developed a standardized reporting system for the radiologists to use when they're the lung screening CAT scans. And it is modeled after the BI-RAD system that's used for mammography. Basically just allows for standardization within the radiologist practice and allows for easier communication with the ordering providers. So basically with the lung rads, there's kind of 4 main categories. And our categories 1 or 2 are basically that there's no further workup needed, just return for annual screening. And then our categories 3 or 4 are those that need additional follow-up. A category 3 is probably benign, has a low likelihood of becoming a clinically active cancer. And then a category 4 is more suspicious. And usually the radiologist will recommend more additional diagnostic testing within the months after the CAT scan. And then, as I mentioned earlier, we also find some incidental findings, such as thyroid nodules, kidney lesions, aortic aneurysms, also coronary artery calcifications, and potential also issues with the liver as well. So our lung screening program here at Siteman launched in fall of 2016. It was put together by a multidisciplinary committee from physicians from several different departments at WashU. We're now offering screenings at several of our BJC locations. Our program has received a few designations through the ACR and then also the Lung Cancer Alliance. We've been designated as a screening center of excellence. Some unique aspects of our program is that the screenings are read by dedicated thoracic radiology subspecialists at our Mallinckrodt Institute of Radiology. So patients that are seen at Siteman, if there is something found, they do have the option to be seen by WashU Thoracic Surgery for monitoring and management of any abnormalities. We do have dedicated nurse navigators to assist patients and their healthcare providers through the process. We also have a patient database that allows for tracking of key metrics and assessing the success of our program. And then we're also currently participating in a few different research opportunities as well. So as I mentioned, continued annual screening is recommended for all patients as long as they still meet the screening guidelines. And we do mail patients a reminder letter every year to remind them to meet with their healthcare providers again when they're due for their annual screenings. Patients do have to have a new order every year from their provider. And we do have a few patients already where the cancer wasn't present on the baseline lung screening CAT scan, but then was caught on the 2nd or 3rd year's exam. So we really, really do stress the importance that this is an ongoing process and it's important to come back annually. So our program does also place an emphasis on smoking cessation. As Dr. Chen said, you know, we're always reminding patients that it's never too late to quit. And quitting smoking reduces their risk of developing cancer and other smoking-related disease. So just to give you some high-level stats, we have almost 2,000 patients enrolled in the program. 14% of patients screened at BJC do need additional follow-up. And 15% of those screened do have an incidental finding found. So far, from the 3 sites that I cover, we've diagnosed 75 cases of lung cancer, and 65% of those are stage 1. So to decide if yearly screening is right for you, or maybe friends or family members, the best way to decide is to encourage them to talk with their doctor, review the pros and cons, and think about what screening is like. And then, just encouraging people to make that decision with your doctor to decide what is best for you. And then just wanted to quickly touch on the symptoms of lung cancer. If someone were to be experiencing any of these symptoms, certainly contact your doctor right away. A bloody cough, having a change in a cough or mucus, weight loss, loss of appetite, just feeling very fatigued and tired, or any chest pain that is worse with deep breathing. So I just certainly encourage you all to help get the word out about lung screening. We still have a large number of eligible but yet unscreened individuals in the St. Louis area. And please feel free to contact me or others if you have questions about the program, or if you might know someone that would be eligible to participate. And here is my contact information. And I know that was certainly a lot to digest, so I will end here and see if we have any questions.
Yes, thank you both for that presentation. That was really wonderful. And some of these questions may be for one of you in particular, so just kind of jump through if you think that you're the best person to answer it. We got one about a question about cigarettes with or without filters. I know that, is there much of a difference when you're smoking a filterless cigarette as opposed to a filtered cigarette?
Dr. Chen, do you want to take that one?
Yes. Hi, can you guys hear me okay? Yeah, well, great question. I really appreciate the audience really, be here on a sunny day and kind of try to think about these topics with us. So yeah, so, this is a great question about filtering for harm reduction, right? So, and, over time, there are all these different variants, right? So like, maybe people think, well, adding menthol, is better. Some people believe that. Yeah, if you put a filter, that's more helpful. And I know some people will say, well, you just don't inhale too deeply, right? And then you can just like, all these different techniques for harm reduction. And so I want to compliment really the motivation behind this question is that, is there a good way that I can improve health one step at a time, right? So, and of course, with COVID, we're all familiar with, like, we all wear our mask, right? So, that the filter does kind of provide some sort of filtering for the person who used the filter, and really doesn't do much for the second hand or third hand. My answer would be the use of filter has not been found to be a significant, effective strategy to reduce the harm. Primarily, I think that in tobacco, if we think about cigarettes or the combustible products, there are like 3,000 carcinogens kind of identified from the combustion itself, because it's just the leaves, right? And then we burn the leaves. So I think the filtering is not really selective, and also it's not complete. And then, I share this news of like 1 cigarette per day can cause harm. So the research is really showing that like it's hard to find like a safe amount of tobacco that is for human body. So, but I don't want to, use my answer to really discourage people who want to go for harm reduction. I would say instead of using filter, try to decrease the number of cigarettes, the duration, the quantity, because I think it's all about like how much of the toxins you actually expose your lungs to, right? So I like this kind of thinking along these lines. I would say clinically, we don't really recommend use of filter just because of it hasn't really been shown to be significant. But I think, as much as you could, reduce the time, the quantity, will be very helpful, and it all needs to be kind of applauded and congratulated upon.
Yes, I think that it kind of all falls into anything you can do to decrease, the amount of the potential for damaging your body is probably a good thing until you can get, to a cold turkey, stopping altogether.
Yeah.
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 And you talked briefly about comparing the death rates to different cancers. And one of the questions came up that how we can compare death rate from breast cancer or prostate cancer, which there really aren't things that there are many factors we can do to increase or maybe decrease those things if they're hereditary. But with lung cancer, that seems to be something that can somewhat be more under our control. Do you have an idea of what percentage of lung cancer patients were smokers?
Yeah, so I believe it's around 90%.
Wow.
Would you agree, Dr. Chen?
Yeah, definitely. Yeah, so you're right. The joke is that if you have lung cancer, you always have to kind of make a disclaimer that like, I'm not a smoker, right? So yeah, so lung cancer, I would say yes, lung cancer, 90% or more smokers, but I think more recently there is a growing trend of non-smoker lung cancer. And with the air, with a lot of the conditions. So I do think that is growing, but I like the comment a lot about what you said about your control, right? So the environment and the genetics, I think actually for all cancer, we actually have more control, and some people have some vulnerability for certain condition. One thing we found that even if you have a high genetic risk for lung cancer, but if you quit smoking, you can reduce your risk so much better than even compared to people with low genetic risk for lung cancer. So yeah, so it is in your hand. You can actually kind of undo the genetic risk that you're born with.
Wow, that's really great. I thought that number would have been high, but 90% was, yeah, that's really high. That's pretty amazing. Do you feel that we have enough data collected to know the long-term effects of vaping? I know it's still kind of a relatively new market for that, but do we really know what the damage is? Is there enough data out there on that?
Yeah. And I would kind of answer, and then Anne can also add. So long-term safety for vaping. So I think vaping has come out now, now we're at 2020. So it's been kind of coming on, I think, maybe for 10 years, it's been some time. Of course, as you probably know, the lung cancer data comes out, like smokers don't get lung cancer. Smokers start smoking in their 15, teenage years, but they don't really get lung cancer diagnosis until they're 50 or 60, so if you look at the curve, there's this lag of like, oh, we have the epidemic for smoking, and 40, 50 years later, we have this epidemic of lung cancer. So I would say the data for vaping, is long. We have about 10 years, but that's kind of short compared to the type of outcome that we're looking at. Cancer does take a lot of time to occur. But I would say that the harm for vaping is definitely lower than tobacco. So I think there is no question about that. Because the harm of tobacco is really, really high. You know, I would always tell my patient, well, the harm of tobacco is like a ceiling. The harm of nicotine is low. You know, it's not zero, but it is much lower. And so back to the vaping, I think it is a wonderful harm reduction for smokers. But for growing brain, you know, for like a 12-year-old, vaping is, you know, having nicotine, you know, chronic nicotine exposure and other things for a learning, developing brain is probably a bad idea. So, you know, our country is kind of juggling with, are we helping our older people who want to quit with vaping, but then we expose our younger kids who now experiment. So back to your question, I think the harm really, you know, varies, and we have so much to learn.
Yeah, so much more than we can cover in this 1 hour, unfortunately, and we are up against it. So I want to take the time to thank you both for taking your time out on this lovely day to come and talk with us about healthy lungs. It is greatly appreciated, and I will make sure we have all of your contact information available for those folks that were with us today, and those that will be joining us on a recorded version as well.
Thank you.
Yes, Judy, I don't know if you have anything you'd like to add. I think that was a no and a thank you.
I'm on mute still,
There you go.
sorry. Yes, I said thank you twice now. Thank you very much.
Yes, thank you. Have a wonderful day, everyone.
Okay, take care.
Much
Bye-bye.
appreciated.
Bye.
Take care.
Joining us. Take care, everyone.